is going to, Dr. John Neary, who is going to introduce our speaker.
Thanks, Dr. Verhovsek. It's my pleasure to welcome my colleague, Dr. Lauren Lapointe-Shaw, to give grand rounds today on the very timely topic of preventing medical readmissions. Dr. Lapointe-Shaw, MD-CM, PhD, is assistant professor and clinician scientist in the Department of Medicine at the University of Toronto, and a staff general internal medicine physician at the University Health Network. Dr. Lapointe-Shaw holds research appointments at the TGH Research Institute, the Women's College Institute for Health System Solutions and Virtual Care, and the Institute for Clinical Evaluative Sciences. She has broad expertise in using health administrative data and observational research methods to measure the quality of healthcare. Her recent research is focused on in-hospital and outpatient care and the organization of physician services. In 2019, she was awarded the CIHR IHSPR's Rising Star Award for her work relating to the transition home from hospital. And you can follow her on Twitter at Lapointe-Shaw. Thank you, Dr. Lapointe-Shaw, for speaking with us today. Having just had a readmission yesterday, I'm interested in hearing your tips.
Fantastic. And I believe you and I actually met through Twitter. So it just demonstrates the power of these Twitter connections.
Good, that's true.
I'll start just with the requisite conflict of interest slide. So I actually have no funds from industry of any kind, but just for your interest, I have my sources of grant and research support here, including CIHR and basically the institutions where I have appointments. So the objectives of my talk today will be to develop an understanding of readmission avoidability, to learn about evidence-based transitional care, and to discover how we, and when I say we, I mean we in Ontario, measure up and where some opportunities for improvement lie in our current processes. And I will start with a clinical case. So this is your patient, an 80-year-old woman who is community dwelling. She's admitted for pneumonia and hyperglycemia. You treat her with supplemental oxygen, antibiotics, and her insulin dose is adjusted. After 3 days in hospital, she's off oxygen and she's ready for discharge. What can your team do to reduce her risk of readmission to hospital? And we'll launch right into the context. So why are readmissions so important? Well, we know that they're extremely common. So on average across Canada in 2020, the readmission rate was about 9.4%, but it is higher in medical patients. They're quite costly, costing over $2 billion in 2019. And of course, when you think about the patient experience, the fact that they're readmitted means it's a marker of ongoing morbidity. So it's not a good thing on the patient side either. Here you can see readmission rates across Ontario according to the type of admission, just again demonstrating medical admissions and return emergency department visits tend to be higher than what we see on the surgical side, and definitely much higher than obstetric admissions. And it may seem to recent grads and trainees that readmissions have just always been a natural focus of a lot of research and improvement initiatives, but actually that's only partly true. So in 2012, the Centers for Medicare and Medicaid in the US introduced this hospital readmissions reduction program. And that changed the landscape completely. So this tied funding for hospitals to their standardized readmission rates, meaning that hospitals that had higher than expected readmission rates would actually have financial penalties. So suddenly there was an additional incentive to really innovate rapidly and find ways to prevent readmissions wherever possible. And also it allowed for a clear business case, right? Because you didn't want to face these financial penalties. So suddenly that freed up resources to pour into transitional care programs to try to prevent these costly readmissions. So since the HRRP came out in 2012, there's just been an explosion of research related to preventing readmissions. So it can be a lot actually to digest, and hence that's why this is sort of the topic of the talk today, to have a broad overview of the landscape of preventing readmissions. So imagining our patient, we'll call him Bob here, he's sort of walking this tightrope between hospital care and community care. And we know that patients have a big voltage drop in care because they're getting monitored constantly in hospital, and then we sort of send them off into the void. And so there's many ways that he can fall off his tightrope. We will call those transitional failures. And these transitional failures have been well documented in the literature, and a lot of this is actually literature led by Alan Forster, and it's quite, it's older literature now, but I'm pretty sure all these things are still happening. So they include things like patients not fully understanding what they're supposed to do when they go home. And really, this is not a patient failure. This is clearly a communication failure on our side, the provider side, including things like ensuring the proper interpretation services when needed. There's discontinuity between inpatient and outpatient providers that happens in many different ways. So incomplete or missing communication. So sometimes those discharge summaries, they just never come. Failure to follow up on results. So failure to, on our side, to flag that a test is still pending or needs to be followed up on. And then on the outpatient side, failure to follow up on the result. A lack of clinical monitoring for the relevant deteriorations that could happen related to whatever your patient was admitted for, and then lots of avoidable adverse drug events. So drug events are actually the most common adverse event after hospital discharge. So, you know, it might be easy to say, okay, well, there's lots of transitional failures that I just highlighted. And so that kind of sets your mind up to think that, hey, maybe all these readmissions are avoidable. Maybe, you know, maybe readmissions are a never event, as I once heard a hospital administrator say. But in fact, nothing could be further from the truth. When we look at how avoidable readmissions are, it's not really as high as we would hope. So first, let's talk a little bit about how readmission avoidability is measured. And it's measured in a range of ways. The gold standard is kind of a clinical chart review by clinicians who have the knowledge to determine whether something seemed avoidable or not. Obviously, there's a lot of subjectivity there, and it's a labor-intensive approach, but it is the gold standard. Other approaches that have been described in the literature include things that are based on the type of diagnosis for the readmission, and this depends on things like ambulatory care sensitive conditions. So certain conditions, if you're hospitalized for them, the thinking goes, that by definition is avoidable. Now I have some, I'm not entirely sure that that argument is 100% valid all the time, but anyway, it's certainly an easier approach to implement than the labor intensive chart review. The timeline of admissions. So I will get into this a bit more later, but there's evidence supporting the fact that shorter interval readmissions are more likely to have been avoidable. So sometimes in some studies, they call these shorter interval readmissions avoidable by definition. And then finally, some studies use an algorithm where they've actually developed a model to predict readmission avoidability. And then they apply that to the literature. So a whole bunch of different ways that avoidability is kind of defined. And again, the gold standard is often this labor-intensive chart review. And this systematic review is, it's getting a little bit older now, but essentially it still holds. The median proportion of readmissions deemed avoidable was only 27%, with some very wide confidence intervals from varying across studies, sorry, not a confidence interval, but across studies from 5% to 79%. So not a ton of certainty, and also that point estimate is much lower than we would hope. We would hope that a lot of these readmissions were avoidable. And that 27% happens to also be the percent that was found in a US multi-center cohort study where they again dove into the cases of readmission. So a detailed chart review to find out what proportion were deemed preventable. And so that number landed exactly where the systematic review did. So I'm pretty confident that that 27% is probably pretty close to accurate. Of course, it's going to be different across settings and patient populations. In this study, they found that half of these avoidable or preventable readmissions represented gaps in care during the initial inpatient stay. So presumably then the other half represents gaps on this sort of outpatient side, but the gaps on the inpatient side, which clearly I care a lot about, being a general internist who takes care of patients on the inpatient side, were failure to relay information to outpatient providers, premature discharge, so when the patient was actually still clinically unwell, and lack of goals of care discussions. Now, and this is what I was talking about earlier. So this is a really interesting study out of the US where they looked at readmission avoidability according to the timing of readmission relative to discharge. So on the x-axis on this figure, you have the post-discharge day. So how many days post-discharge that person was readmitted. And then on the y-axis, you have the measure of the proportion that was deemed preventable at chart review. And it's quite amazing. You actually, in this particular study, they found there was almost like a natural drop off in that proportion that was preventable at the 1 week mark. And so you see that after the 1 week mark, you end up with sort of something around 20%-ish are preventable. But before that, it's as high as like 35%. So this does provide some evidence that perhaps the shorter interval metrics identify more avoidable readmissions. And this finding and other findings since do support the argument that maybe we shouldn't be focusing so much on 30-day readmissions as a marker of like an opportunity to improve. We should be focusing a bit more on 7-day readmissions, particularly if we are the inpatient providers and we're trying to improve the things that, you know, we have direct control over. So what are the interventions that actually can make a difference to move the needle, given that only about 27% of these are avoidable? And I will start just by saying there's challenges in interpreting the overall literature, of course, as always, because across studies, it's different populations who are being compared. The interventions are complex, meaning they have lots of different moving parts. And so comparing them directly one to the other is not as straightforward. This isn't drug research. It's messy. Often lots of important confounding variables are missing. So we don't necessarily have detailed, for example, functional data. So what patients can do, whether they have functional decline or not. And of course, when we're talking about observational studies, although fortunately there are many RCTs in this literature, but in observational studies, there's always the issue of confounding by indication. For example, I did a lot of work looking at follow-up after discharge, and it only makes sense that your patients that you're most worried about, you are going to make sure they have follow-up. So then that's going to confound your findings as to whether follow-up is beneficial. So I'll take you through sort of the landscape, which fortunately there's been a ton of systematic reviews, but this is one of the earliest ones. And it was helpful because it created this taxonomy of interventions to reduce 30-day rehospitalization. So categorizing interventions into pre-discharge, post-discharge, and things that really bridge the transition. They found at the time that no single component or intervention implemented alone was regularly associated with reduced risk. And essentially, the next few systematic reviews kind of build on this same theme. This was a really cool, I think, systematic review by Burke, where they actually decomposed these multi-component interventions into their subcomponents and categorized them according to this ideal transitions of care framework. So they kind of lumped the different pieces into these categories, and then they've determined which of these categories actually had the strongest association with a positive study, so i.e. like a beneficial effect in preventing readmissions. And they found on average that interventions studied included 3.5 domains each. So definitely they all had multiple components. And the components with the strongest association were monitoring and managing symptoms after discharge with that odds ratio of 8. So that is a domain that includes things like telehealth, phone calls to the patient, follow-up visits, and either in the office or at home, and then a clinician available to respond to concerns. So any or all of those things. Other domains that were strongly associated were enlisting help of social and community supports, pretty self-explanatory. That's often things like, that would be like home care in our setting, and then educating patients to promote their self-management. Again, using things like teach back and principles of health literacy, and teaching some self-advocacy as well. The number of domains included was significantly associated with success in reducing readmissions. So for each additional domain, there was an additional odds ratio for preventing readmissions of 1.5. So essentially, the effects seem to be additive or enhanced. There's synergy between the different factors. Another systematic review actually graded the multi-component interventions into the degree of what they called comprehensive support. So comprehensive support, they graded according to how many of these factors were met, whether it increased patient capacity for self-care, had at least 5 components, at least 5 patient contacts, and at least 2 people involved in delivery. And then they found a dose response effect as well. So similar to Burke. So the more comprehensive the intervention was, the greater the effect on reducing readmissions. You can see that relative risk gets lower and lower with the more points they got. And finally, the sort of maximum, the pinnacle of EBM, the review of systematic reviews found that successful interventions tended to be more comprehensive, involve more aspects of the care transition, include components before and after discharge, and yet still be flexible enough to accommodate individual patient needs. So to summarize all these systematic reviews, there was no magic bullet. In other words, more is more. More components actually leads to more benefit. And this is notable because in some ways it's sort of, I think, disappointing for many, because it means, resources need to go into the transitional care bundle. You need personnel. You need to do many different things. It's also notable because some people will say, well, hey, there was a systematic review of post-discharge phone calls, which is true, which found no benefit of this specific component. And so then, why should we be doing that? But yet the post-discharge phone calls are a component that is present in many of the successful multi-component interventions. And we know that that is part of the monitoring and managing symptoms after discharge, which you saw in that Burke review actually has the strongest association with the benefit. So I think it just drives home that we can't be sort of reductionist about these subcomponents. Successful interventions are going to involve lots of different parts. And just some more recent literature updates from the real world. So this is actually like observational data from 10 Veterans Affairs hospitals. And they try to actually score the hospitals according to how many recommended care transition processes they used after interviewing staff and observing exactly what their processes were. And then they plotted this against the hospital's risk standardized readmission rate. Now, of course, acknowledging 10 data points is not a lot. And obviously, this plot could be interpreted in various ways. And an R-squared of 0.61 is not huge, right? It's not 0.8, it's not 0.9, but still it does appear that there seems to be some inverse relationship, at least in this particular set of hospitals in the VA, with hospitals having more discharge processes actually having a lower risk standardized readmission rate. So that was encouraging and consistent with all the existing systematic reviews. Now, another literature update, which I will say in some ways, the exception proves the rule. So this is a 2021 systematic review that looked specifically at communication interventions. Now, that's a bit of a broad term, and it included a mix of medication counseling interventions and then education on disease management, and then a handful of other specific communication things that didn't fall in those 2 categories. And they found that communication interventions on their own did seem to have a beneficial effect. So this may be the exception to everything I've said so far with respect to more being more. And how I would fit this into the existing literature is that I would say more is more, multi-component is essential. However, make sure that at least one communication intervention is part of your multi-component bundle, because this part does seem to have some really robust evidence. So I thought I would give you an example of what some multi-component interventions kind of look like, using the example of Project RED, which is the re-engineered discharge, which was developed in Boston University Medical Center, but endorsed by the Agency for Healthcare Research and Quality in the US, the AHRQ. And they developed a toolkit to help kind of spread this to other hospitals. And this is really just kind of an example because, of course, all these bundles are slightly different, but they do tend to have some common elements. So a focus on the planning around the discharge process in terms of who's going to follow up results, making appointments, organizing services. A focus on medications and medication reconciliation. There's a part, of course, related to patient education around what the plan will be when they go home, what to do if a problem arises, and then assessing the degree of patient understanding. Related to assessing the degree of understanding, I wanted to briefly touch on teach back, which is something I think we probably don't do enough of, which can feel a little hokey. It's the idea that, you get the patient to teach back to you what you just told them. And there's some useful scripts here to help you feel less hokey about it. So things that you can say, like, just to be safe, I want to make sure we're on the same page. Can you tell me what the plan will be when you go home for your medications? So I thought this type of thing was helpful. This is also on the AHRQ website. And then finally, they tend to include a follow-up piece related. It tends to contain things either like a phone call or a follow-up appointment. So clearly these interventions, as I've sort of highlighted, they're complex, they involve dedicated personnel, and so they're resource intensive. So naturally, there's been a kind of desire to figure out who should we prioritize for these interventions, especially because they cost money, right? So if we were to just roll this out to everyone, that would end up costing quite a bit of money. So is there a way that we can tailor it to the people who are most likely to benefit? And so this has been done in the past really by focusing in on high risk patients, meaning high risk for readmission. And there's so many different scores that have been developed to find these high risk patients. Some you may have heard of over the years, the LACE Plus hospital. I mean, there's too many to count. There was a review of them in 2016 and found that there were 73 at the time. And only 2 of them actually identified potentially avoidable readmissions. All the rest were just readmission predictors. And these scores tend to contain these types of variables related to patient and hospitalization factors, many of which are readily measured in electronic medical records. And the idea kind of goes, well, if people with these characteristics are high risk of readmission, it makes sense to hone in on that group for these interventions for a couple of reasons. First of all, from like a researcher perspective, we know that if we have more event rates in a particular group, then it's going to be easier to detect a difference between groups. So you're going to have better power with a smaller group of patients. If it's a lower risk group with low event rates, then you need to recruit way more people to see a difference. So that's kind of the researcher side. But then practically in the real world, we also think, hey, this seems to make sense intuitively that if we want to make a difference for patients who are getting readmitted, let's start with the highest risk patients because, we've got to be able to make a difference for those patients. Unfortunately, it doesn't always quite pan out that way. So some examples of some multi-component interventions that really in theory seem like they should have worked, but didn't. I'll just share these with you. So one is the virtual ward, which was led out of course, U of T based hospitals by my own colleagues. And it was quite labor intensive intervention. So they identified patients that are high risk of readmission based on the LACE index. And I have a calculator here for you that kind of showed how you could calculate the LACE. And then they were randomized to either usual care or to this, this virtual ward team, which was a combination of care coordinators. You had like home care coordinator types, and then allied health and pharmacists and physicians who did a combination of telephone, home visit, and clinic visit follow-ups for several weeks after discharge. It was really quite a hands-on thing. I actually attended on this virtual ward myself. And yet, you know, no statistically significant effect of the virtual ward model of care on any of the outcomes or any of the readmission outcomes at 30 days or longer. It's quite a disappointment. And then another similar disappointment is the Camden Hotspotters trial. So this is US based. It was Camden area hospital system that basically developed an intervention focused on patients who had had a lot of previous healthcare use. So these were very complex patients. They had at least 2 chronic conditions and at least 2 of a series of different medical or social or mental health factors that kind of made them likely to be high users of the healthcare system. The team was, again, multidisciplinary: nurses, social workers, health coaches. It involved home visits, helping patients schedule their appointments, get to their appointments. They actually went and measured patients' blood pressure and blood sugar at home, and they gave them all kinds of coaching so that they would advocate for themselves and connect them with social services. So again, very labor intensive. And you could see on this graph that it made no difference. So the missing bar corresponds to time 0, which is when they were randomized. And you can see here the number of admissions per quarter in the treatment and control arms. So control would be like usual care, and then treatment is the ones who got this intensive intervention. And you can see that there was no difference in the subsequent quarters. And this was a huge disappointment. And you know, people struggled to explain why this intervention didn't make a difference. And there was a series of reasons, and there was an editorial about this even. You know, many factors. So one thing is, you know, when you identify people as high risk based on previous healthcare utilization, you often end up with a bit of regression to the mean, meaning people tend to kind of over time not use healthcare resources to the same extent as they did previously. There's always issues with the things that make patients high risk also make it more difficult for them to adhere to the protocol. And as demonstrated in this study, but also in other research, healthcare contacts tend to actually lead to readmissions in some cases, right? Because you detect clinical decline. You have an opportunity, a nurse actually sees you, and that can actually lead to a readmission, which is appropriate. But then, you know, that means that you don't necessarily see the same kind of drop in readmissions. Many people talk about these patients being too high risk, and it was the same discussion about the virtual ward. They were too high risk, and ultimately the risk may not have been modifiable. So what does this mean, the risk being modifiable? In the context of transitional care, what I think this means is, you know, we need to focus on patient characteristics that actually lead to transitional failures. So we know that there's patient characteristics that lead patients to be readmitted. So for example, one of the classic ones are, you know, diagnosis of CHF or COPD. These conditions are notoriously challenging, and you know, we know these patients are going to have a lot of healthcare use. But if that risk is entirely tied to the medical condition, a transitional solution may not always be the answer, because they may not actually, depending on the patient, you know, they may already be able to get to their follow-up appointments. They may already be able to take their medications. I mean, of course, we have to make sure that they can do all those things. But if the only risk factor is the diagnosis itself, then that may not really be as modifiable as a patient who has characteristics that make them more at risk of transitional failures specifically, i.e. Things like language, like they are not able to understand the discharge instructions because we didn't use interpretation services appropriately. Mobility issues, so it's going to be very difficult to get to follow-up appointments. Financial issues, a lack of social supports. These are types of characteristics that may link up better with specific transitional deficits that can be remedied by transitional interventions. So as an example of a screening tool that operates a little bit more in this avoidability framework is the BOOST, which was endorsed by the Society of Hospital Medicine. And they talk about these 8 Ps. So the Ps being these, well, the ones you can read here, but they actually map them directly to specific transitional interventions that directly sort of address the concern. So for example, if the issue is physical limitations, then you engage family caregivers to ensure ability to assist with post-discharge care, assess for home services, there's a follow-up phone call. So kind of more tailored intervention, which makes it harder to study because of course there's going to be heterogeneity in what people get, but it also reflects a bit more like common sense and sort of decision-making by clinicians in the real world, where you kind of look at your patient and figure out, well, what exactly does this patient really need? And I'm going to tailor what I do to my patient's specific needs. So now we're going to take a look a little bit at how we are doing, we meaning Ontario, looking at the recent Ontario Health Quality, recent meaning immediately pre-COVID, which I guess is a while ago now, at their report Transitions Between Hospital and Home Quality Standard, which was really a quite valiant effort by some of my colleagues, led by Tara Kieran, who's a family doctor out of St. Michael's Hospital. And they've identified several system level problems, which I think probably won't surprise many of us, but it was important to get these things out there. So shortage of home care personnel was the biggest issue, the biggest transitional care issue we face in Ontario, and the quality of home care services provided. Inefficient and suboptimal ways of sharing patient information. Looking at you, fax machines, right? Insufficient awareness of and access to community mental health and addiction programs, issues with the accuracy, timeliness, and completeness of discharge summaries. And finally, in many cases, important treatment modalities are not covered by our public insurance. And there's going to be an impact on those living in poverty in terms of their ability to successfully transition home. So wait times for home care were identified as like a major concern. So this is the median number of days that new patients wait for their first home care visit after discharge. So the Ontario average is 3.8 days, which I think is longer than, it was a surprise to me, actually. It's longer than I would expect, right? Most of the time we send patients home and we kind of think that that home care is like starting that night or the next day, but they're waiting many days. So they came out with a list of quality statement topics and detailed recommendations. I encourage anyone interested, of course, to check out the full report. But I thought using this framework, I would say, just mention how things are going where I work, which is the Toronto General Hospital. Like, how much of this stuff do we do and what do we not do? And what are the opportunities for improvement? So they strongly recommended information sharing on admission, and particularly using an automated real-time electronic notification to the outpatient providers, including the home care providers, so that they were able to then communicate back to the inpatient team about important information about that patient. Definitely that is not happening where I work. I don't know if it's happening where you work. It sounds like it would be wonderful, but we need the supportive infrastructure. Comprehensive assessment of patient needs. I think we are doing. It happens somewhat informally. We do involve patient family caregivers in the transition planning. With respect to the education, training, and support of patients and family and caregivers, this is definitely done informally. I wouldn't say that we use teach back as much as we should. We definitely need to do this more. This is the main part where I think we have a lot of room to improve around the transition plan. So The team, the Ontario Health Quality Team recommended a written transition plan developed by and agreed upon in partnership, not just with the patient and caregiver, but also the outpatient team. So the primary care, home and community providers. They're shared with the primary care, home care and community providers within 48 hours of discharge. So no discharge summary coming 2 weeks later. And there's a clear phone number of a person to call if the patient needs help. So I really wish we had these things. We do give them a discharge summary, of course. Sometimes we use this patient-oriented discharge summary, which I'll show you on the next page. We have a transitional care coordinator, but they've been somewhat co-opted by our hospital bed flow. So it's not really, they're not fully available to really be the captain of the transitional team. And we don't have a number to call for issues, which is really unfortunate. But we're hopefully moving towards some of these things because, of course, our CEO, Kevin Smith, is the champion of integrated care. So hopefully we'll see some improvements in these areas. This is the patient-oriented discharge summary, which you may have heard of, which was co-designed with patients and caregivers. It's a tool that patients populate with their physician to really help to integrate and make it clear to them what the plan should be when they go home. We don't use it as much as we should. You know, it ends up being one additional page on top of sort of the discharge summary, prescription, everything that we need to do. But certainly I think this is helpful. It's just we definitely need to use it more. Medication, coming back to the quality statement topics, medication reconciliation and review. So reconciliation is actually a hospital accreditation standard in Canada. So that part does happen as long as it's Monday to Friday and it's regular work hours, because on weekends, we don't have the pharmacist coverage to sort of help with this. And so the medical team will do it. However, you know, I know kind of anecdotally, it's always going to be better when we have the pharmacy team helping. And finally, the coordinated follow-up and medical care. So they recommend that follow-up appointments be coordinated and booked before the patient leaves hospital. That is like the dream. In my world, that doesn't really happen, partly because we don't have the admin support to help with that. And so the medical team is already juggling so many things. They can't sort of be on hold waiting to book these appointments. Definitely room for improvement here. And finally, with respect to assessing out-of-pocket costs and limits of funded services, done rather informally as well. So clearly, you know, as care providers, we know a lot about what ideal care looks like. There's various checklists to help us, but they can only do so much because a lot of this comes down to supportive health systems. So leadership and policy development at the hospital level around what a good transition looks like could really help here. Having supportive IT in the sense of, for example, the automated notifications back to the outpatient providers that your patient was admitted, but also supportive IT to enable things like audit and feedback around how we're doing with our discharge processes and what our current readmission rates look like. And finally, as we talked about, the best transitional care interventions involve dedicated personnel, and that actually takes resources and money. And sometimes there's some return on investment, but I think we can't necessarily wait for the clear business case. At some point, we have to recognize that these ideal transitions of care elements are just part of good care. And, you know, we may need to just take a leap of faith to implement them into our standard practice rather than waiting for them to be cost saving in some way, because they may not be, but they may just be the right thing to do. As an example of the kind of tools that can support audit and feedback, I know that your hospital, St. Joe's, is actually part of the GEMQuinn My Practice, or that you guys, the GIM team, the General Internal Medicine Service, receives these My Practice reports, I believe. This is an example of a type of report that the General Internal Medicine physicians receive through the GEMQuinn program. And I'm very pleased that they incorporated the 7-day readmission metric, because as we discussed, shorter interval readmissions are more likely to be avoidable. So you can actually see your own performance. I think this is actually my report. I think it is 7-day readmission rates over time, to see how you're doing relative to your peers. And that can be helpful to gauge, should I talk to my colleagues about what they're doing that I'm not doing to see how I can improve. And the interface also links to a bunch of toolkits to help figure out next steps to try to improve. So there's still lots of unsolved mysteries in the transitional care literature. The main things being, how do we find the patients whose risk is most modifiable? And then, of course, how to implement and sustain these complex transitional care bundles. How do we make them part of standard care when we know that they require resources and healthcare dollars are just constantly shrinking and more constrained over time? I don't have answers to those questions, but those are the key things that I'm thinking about. So coming back to our clinical case of your 80-year-old female patient who's admitted for pneumonia and hyperglycemia, and she's ready to go home now. So what can you do to reduce her risk of readmission? Well, you could use the BOOST tool, and you figure out based on the BOOST tool that she has some functional decline and she lacks social supports. She's very isolated. So based on that, you determine that you should get her a home care assessment. You make sure that home care providers receive the discharge summary. You book her follow-up within 7 days of discharge. She gets a transition coach whose number she has to check in with, and this person checks in with her at 72 hours. And so that would really be, I think, pretty ideal care. So take-home points overall are that about a quarter of readmissions are avoidable, and that the best interventions are multifaceted, multi-component. They include in-hospital, transitional, and post-discharge components. They involve multiple different domains, and they require dedicated personnel. And that when we look at Ontario, and when I look at my hospital specifically, there's many opportunities to improve here. And that's it. I invite your questions.
Wonderful. Thank you so much for that deep dive into all that is preventing medical readmissions. So I'm going to invite any questions that folks may have. I know that Dr. Ann Holbrook already has mentioned that she does have a question. So we'll start with you, Ann.
Hi, thanks. Lauren, that was excellent. Excellent topic, excellent presentation. It is so heartening to hear that some young clinician investigators are working this area. I'm a clinical pharmacologist. I have a comment and a question. We've been working on medications as sources of readmissions for so long. It's actually becoming almost discouraging. I have a couple of randomized trials ongoing, which I call the projects from hell, because getting them done in COVID times has been extraordinarily difficult. But you mentioned a whole bunch of the key problems. We have discharge reconciliation or medication reconciliation. We don't have discharge reconciliation in Hamilton. Actually, we have admission medrec, and medrec is not medication management, which is the higher level that, you know, clinical pharmacologists are expert in, but there's like 5 of us in the country, sort of thing. So my question has to do about what you think of the importance of medications overall. And one of, I would think, the simplest suggestions is for a remedy, can we not at least get an organized agreement on a standard discharge summary, which includes an accurate medication list? Like we have EPIC, this, as somebody called it, the Ferrari of EMRs, and yet there's inaccurate medication lists going out to family doctors every day from our hospital. And in fact, the meds aren't actually mandated to be part of the discharge summary. So I wondered what you thought might be the top simple things we could do at discharge around medications, and where you saw what really is the low-hanging fruit overall. Maybe it's not really medications that we should be doing in, you know, what is everywhere in Ontario, the overworked general internist, the very busy family doctor, and the patient that doesn't, even with the best intentions, is not going to follow up 100%.
Yeah, wow. I mean, such great questions, and clearly, like, honestly, you've kind of taught me some things just in this question, which I guess that this is quite interesting to learn that sort of the pharmacist involvement in the discharge med list is not necessarily standard. So the accreditation part is the inpatient, the arrival reconciliation. So I do think that first off, I mean, the most common adverse events post-discharge relate to meds. I think no question there's a logical link between these medication interventions and preventing readmissions. That being said, I'm sure you probably know the systematic reviews that have looked specifically just at the medication review components. The findings are inconsistent, and so it's not a slam dunk that it prevents readmissions, although it does seem to prevent adverse drug events. So, sometimes this is used as an argument against some of these medication reconciliation things, but I do think it's just really part of good care. Like, as you say, it's essential that the list that goes out is the correct one. So I think that should really be part of the accreditation standard, recognizing that it would involve some increased demand on either medical teams, pharmacists to make that happen. And a discharge prescription should go in every discharge summary. How do we make it easier? The other thing I'll mention is just the role that meds check and community-based interventions could potentially play here. More of a connection between inpatient pharmacists and outpatient pharmacists to ensure that there's some additional reinforcement at the point of picking up meds by the patients of, like, these are the changes that are made. This is now the accurate medication list. That I think there's a lot of room for that to be an enhancement. I don't know that there is any clear low-hanging fruit other than maybe saying that, well, look, if you have Epic, like, it should be pretty straightforward to build into Epic that you must have the med list. And kind of provide reconciliation responses, like the home meds show up. This is how it is where I work. I don't know how actually, we're about to get Epic, so I don't know how it is in Epic, but our previous one, the DC meds automatically populate with the home meds and you have to reconcile on it. So I think that type of model is good because it forces you to actually address both the inpatient prescriptions and also what they were on pre-admission. I hope that answers your question somewhat.
Thanks so much for that response. I'm going to take from Anne's silence that she's definitely satisfied with your answer and discussion around that topic. I know that Dr. Neary mentioned that he has a few questions. I also see Dr. Jason Chung with his hand up. So John, maybe if it's okay with you, we'll take Jason's question and then over to you.
Thanks, Madeline, and thanks, Dr. Lapointe-Shaw. That was an amazing talk. I'm the head of service here at St. Joe's for GIM, and so this is obviously a very important subject for us to all hear about and learn about. My comment and question relates to discharge summaries. Yesterday at our Department of Medicine executive meeting, we were discussing the possibility of standardizing discharge summaries, not across necessarily just our own organization within the Department of Medicine, but across the city, and that EPIC is rolling out at Hamilton Health Sciences as well. Is there any role in having standardized discharge summaries is the first question. And the second piece is, do you think that, or what do you think would be the best way of implementing that across the organization? And do you think that will help in reducing these readmissions?
Thanks so much. I have to admit, I can't recall, whether there's clear evidence that shows that standardized discharge summaries reduce readmissions. That being said, again, it's a question of, there's like the EBM purist, and then there's sort of like, well, what is sort of logical and makes sense? And that is, we know that having clear instructions that address, XYZ topics is essential for the patient to know what the plan is. So yes, I am a strong believer in standardized discharge summaries, just because it forces you and it makes it automatic that you need to have a plan for follow-up. And the one we use has a section for instructions to receiving providers, which I really appreciate. So I can say like, name of family physician, like this is what I'm hoping you can follow up on. Name of specialist, this is what I'm hoping you can follow up on. So definitely, definitely, I think this is essential. How to kind of implement, I mean, I think this is the type of thing where, you know, bringing the various service leaders together and working out, you know, what you can all come to an agreement on. I know there are lots of references that can be useful here, like Society of Hospital Medicine. I believe they have a discharge template. I think it might have been developed by my own colleague, Christine Soon. So there's certainly reference materials, and like we could send you ours because we have a standardized one to see what others are doing. I think definitely encourage you going in the direction.
Sounds great. Thanks so much.
Lauren, I wanted to ask, I guess this is a multi-part question about the validity of the readmission construct as a measure what we're trying to get at here, where I feel like this has probably been picked up on because it's a very easy thing to measure in hospital administrative data. First of all, I guess just very straightforward, in the American context, has this metric been hacked by the hospital? So you read about things like admission for observation. Yeah. You know, have they managed to reclassify admissions as something other than admissions? And are these data actually measuring what they're intended to measure? Or have the hospitals found ways to, you know, reclassify things that don't count as readmissions to the point that the measurements are useless? But I guess the deeper part of my question is, you know, you mentioned the idea that, you know, some interventions might improve quality of care without reducing readmissions, because we might say readmit someone earlier, you know, before they get very sick. And clearly, I think there's a trade-off between timing of discharge and risk of readmission. You know, the earlier you send someone home, the more likely they are to maybe come back. So, does it even make sense to talk about readmission as a metric without looking at initial length of stay, you know, length of readmission, intensity of, you know, readmission service, ICU versus ward, whatever? Like, can you even do this?
These are all such great points, and they're like all things that I have ruminated about a lot. You know, when I'm actually doing research related to this type of stuff. So your first point, and I suspect you may already have seen some of these papers, and that's why you're bringing it up, is yes, in the US, after the HRRP came out, they did find that all of a sudden there were all these admissions for observation, that became a new thing that was a way to not admit people 100%. So there is gaming of the system happening. But that being said, in these randomized controlled trials, like presumably both arms would be subject to that, right? So like the literature would be balanced in that way. So that's reassuring, but definitely it is being gamed. And the strongest, I didn't mention it, but in some of these avoidability studies, they actually, the one that looked at what predicted an avoidable readmission, the actual strongest factor that I didn't mention, because it just seems so not, it's like intuitive, but not helpful, was the decision to readmit. So like the emerge doc decide, you know, and if they decide not to readmit, then there's not a readmission. Well, obviously, right? So that's what's being gamed. Your second point about like the readmission construct, trade-offs with length of stay, I mean, so well taken. You know, there's a lot of debate about whether these things are inversely related. I know, so in our Gemini work, using the data for all the GIM inpatient admissions that are part of Gemini, we don't find that there's a clear inverse relationship. So I know we all kind of feel intuitively that, oh, if I keep someone longer, then they'll be less likely to be readmitted. If I have shorter admissions, then it's a direct trade-off. There isn't really evidence when you look at physicians, like across physicians, they don't seem to be trading off one against the other. But I think, you know, we all agree that there is probably some degree of trade-off that we just can't capture fully in the data. And so I don't know, there's not an easy answer, and clearly we all agree that some readmissions are necessary. And the other thing that I will put forward that I've thought about is that we should be looking at things like count of days in hospital over like a 30 to 60 day period, because if you're readmitted and it's very brief, it's very different than being readmitted for many days, and they probably reflect different degrees of sort of badness. And from a patient perspective, like it's meaningful to think about how much of your life are you spending in hospital. So kind of moving to some alternative measures, I think would be interesting as well. There's a lot of ways to explore this topic.
That's great. Thank you. John, are you okay if we go on to a couple of those other questions? Okay, great. So got Dr. Mino Mitri with a question, and then followed by Dr. Anna Matthew, and then there's one question in the chat.
Yes, hi, Dr. Lapointe-Shaw. Thank you so much for your presentation. That was really awesome. My question, so it relates to my subspecialty. So I'm a general interest and I'm a palliative medicine subspecialist. And you mentioned that goals of care discussion actually may have an impact on the readmission. Now, obviously, that's going to be my area of focus of interest. I wonder if there's any studies out there about the role of palliative medicine interventions in the concept of readmission. Because when you mention the phenotype of the patients, particularly of those who have multiple comorbidities, such as heart failure, COPD, I wonder as well, there's probably going to be some elements of functional decline. So when I go on my GIM weeks of service, I don't turn off my palliative care lens, right? I still see these patients and I ask myself, in this moment in time in their acute heart failure exacerbation, where are they in their illness trajectory? Have we addressed the bigger picture? What are the struggles that they're having at home? What's their functional status? Even though they're medically cleared, their volume status is back to euvolemia, but they can't get out of bed, or can they barely get out of bed, right? So these things start to come into play, and there are triggers for readmissions for, a repeat heart failure exacerbation because they're so deconditioned and whatnot. So I wonder if what are your thoughts about having palliative medicine interventions play into the metric of reducing readmissions?
And before you answer, that was exactly my question as well. I'm a nephrologist, and I think just like Dr. Mitri was mentioning, some of the chronic disease populations have higher readmission rates and higher potentially avoidable readmission rates than what you quoted, like 20-25% potentially avoidable or even higher. And and then the readmission rates are higher. And there are some interventions like Inspired COPD where they incorporate the advanced care planning into a chronic lung population. So that was exactly my question. I was just wondering if you had looked, if there was any data on that in general medicine, like advanced care planning and goals of care discussion. So sorry but it's my same question that I had. So
that's awesome.
I think this is an excellent point. And, I'm sure there is. I have to admit, despite appearances, I don't have the entire body of literature at the ready in my head, specifically around this advanced care planning piece. But I would agree that definitely that is logically it should be a component. And so working at Toronto General Hospital, very large cancer population. And so I know that's going to be a huge factor, particularly around, patients are being palliated. Many of them want to go home still, and you're kind of knowing that they're going to be readmitted also. That's likely to contribute to readmission. So I don't have a good answer, but I want to find out more about this, because you're right, it should be part of these bundles, the advanced care planning, certainly where there's a potential for the patient going to a hospice or another place, which will lead to them not being readmitted for sure. Thank you.
Thank you. And that brings us right to the end of our time for today. Perfect timing. Probably we could go on discussing the ins and the outs for quite some time, because in fact, this is so important to our day-to-day lives as clinicians providing inpatient care. I want to thank you so much, Dr. Lapointe-Shaw, for joining us today and for sharing your wisdom and expertise with us. Thanks to Dr. John Neary for arranging this visiting speaker. And to everyone, I wish you all a wonderful day and week. Next week will be Chair's Medical Grand Rounds hosted by Dr. Mark Crowther. So thanks again and take care.
Thanks so much for having me. I'm gonna figure out how to.